2, 1. Please start. We are live.
Good evening and welcome to everyone. We welcome you to the Lung Cancer Conclave 19th November 2022. It has been organized by the Meher Lakshmi ma'am, Associate Professor of Medical Oncology, Nizamabad. Over to you, ma'am.
Thank you, everybody. At the outset, I like to thank the organizers for giving us this opportunity. Today, we will be discussing about the lung cancer and all the recent advances that have been occurred in the development of drugs in lung cancer. We all know that lung cancer is a common cancer, and numerous developments have been made in the management of lung cancer in the past decade, all of which have contributed to the improvement in survival of patient. There was a time when chemotherapy alone was given, and the aim was to improve the quality of life only. But the stress was not made on the survival. But now everything has changed. Each and every drug is adding to the survival. So there are now numerous combinations and numerous new drugs available, all of which are contributing to the improvement in patient survival. So let's see the recent developments, and we have numerous eminent speakers today from 3 states of AP, Telangana, and Kerala. So at the outset, I'd like to invite Dr. Praveena. She's a consultant medical oncologist from Mahatma Gandhi Cancer Hospital, Visakhapatnam. She'll be talking on molecular biomarkers in lung cancer. Dr. Praveena.
Thank you, ma'am. Is my screen visible?
Yes, ma'am. Yes, ma'am.
Okay. First of all, I would like to thank AstraZeneca for giving me this opportunity. Now I am going to discuss about various molecular biomarkers in lung cancer. So when we see the burden of lung cancer in India, we all know this Globocon 2020 data. It is the fourth most common malignancy in both sexes, and second most common malignancy in males. And it is also the fourth most common cause of cancer-related deaths in India. So when you see the evolution of advanced non-small cell lung cancer management, previously we used to give only chemotherapy. After that, slowly EGFR TKS have come into picture. After that, ALK TKS. Now we have plenty of targetable mutations and targeted drugs are there, and many drugs are under studies also. So when we see this picture, almost 50% of patients with advanced non-squamous NSCLC have a driver mutation targetable with a drug. When we see the percentages, EGFR mutations are most commonly we encounter, especially in Asian population. Up to 50% of Asian patients have EGFR mutations. When coming to Indian data, 25 to 30% of patients usually have EGFR mutations. ALK mutations are usually seen in 7%, whereas remaining MET exon 14 skipping mutations, MET amplifications, HER2 mutations, ROS1 rearrangement, RET, all these are seen in single digit, around 2 to 3% ranges. Out of all these, EGFR mutations, ALK rearrangements, ROS1 rearrangement, RET rearrangement, and HER2 mutations, all these are seen commonly in adenocarcinoma, young patients, and non-smokers. Whereas KRAS mutations and BRAF mutations are commonly seen in smokers. Let's discuss about in detail later. So why we should test for these biomarkers before considering before starting systemic therapy? Because patients having these actionable mutations, driver mutations, if we give appropriate targeted therapy drug, we can achieve better survival compared to chemotherapy. If you can see in this graph, patients receiving targeted therapy for the driver alteration usually have better overall survival compared to patients not receiving the targeted therapy. And all guidelines, ASCO guidelines, NCCN, ESMO, and CAP guidelines recommend this biomarker testing prior to taking treatment decisions in advanced non-small cell lung cancer. Additionally, in NCCN and CAP guidelines also recommend KRAS mutation testing also, because recently sotorasib drug has been approved for the management of KRAS G12C mutations in second-line setting. Then what are the testing methods? Previously, oldest method is direct sequencing or DNA sequencing. In this direct sequencing, we used to examine a single gene for a mutation, but it is a slow process and less sensitivity. Tumor mutation burden should be greater than 10% to be able to identify with direct sequencing of gene. But we will be able to only examine a single gene with this testing. After that, LL specific testing has come into picture, like PCR. With this PCR, the targetable mutation gene will be amplified first, then the mutation will be identified. With this PCR technique, we can identify only pre-specified mutations. New abnormalities cannot be identified with PCR, but it is faster and cheaper than single gene sequencing. So it represents a great technological leap from moving from direct sequencing. After that, NGS came into picture. NGS is called next generation sequencing. NGS overcomes the shortcomings of both direct sequencing and PCR. It is called massive parallel sequencing. Simultaneously, we can examine multiple genes. Not only pre-specified mutations, new abnormalities, new gene alterations also can be identified with NGS technique. And also sensitivity of this NGS is also higher. Even samples with low tumor mutation burden, we can consider for NGS testing. DNA-based NGS and RNA-based NGS, two types of NGS are available now. Routinely, we do DNA-based NGS, but in recent times, RNA-based NGS also coming to picture, because it has higher sensitivity for detecting fusion abnormalities and exon 14 skipping mutations when compared to DNA-based NGS. Remaining other techniques are IHC and FISH. With FISH testing, we routinely use for identifying rearrangements like ALK rearrangement, ROS1 rearrangement, and also it can be used to identify amplifications and deletions also. IHC testing we generally use for ALK testing, and there's a screening procedure for ROS1 testing, and it is also a definitive method for PDL1 testing, one and only definitive method for PDL1 testing. So these are the different testing methods for molecular biomarkers. And these are the samples we routinely use for these markers testing. FFPE blocks are preferred. And also when FFPE block is not available, cell block made from the fluid samples also can be used for these biomarker testings. And what is the use of biopsy? For establishing diagnosis. Second one, for histological subtyping, whether squamous or non-squamous, we can differentiate with biopsy. And for biomarker testing, both primary tumors and metastatic lesions are equally suitable. Bone biopsy, we generally do not prefer bone site lesion for biopsy, because during the process of making FFP block, during the decalcification procedure, it may cause degradation of DNA, and the quality of DNA may be poor to consider for further molecular testing. Generally, biopsy from lung lesion or other metastatic sites apart from other than bone lesions are preferable. If recently liquid biopsies are coming into picture, I will discuss about liquid biopsies in detail later. And preferably broad panel NGS testing is preferable to identify these these molecular alterations. These are for all adenocarcinoma patients we consider for this molecular testing, and also squamous MSCLC also it's better to consider for these molecular alterations, and preferably in young patients, never smokers or light smokers having mixed histology. For these patients, it is mandatory. PD-L1 testing is recommended in all NSCLC patients, now squamous and non-squamous. Then what is ctDNA? ctDNA, we all know on blood sample we can consider for ctDNA testing. Then what is the use of ctDNA testing? It is useful for treatment selection, it is recommended in advanced NSCLC to guide treatment selection under specific circumstances like progression of first generation targeted therapies. In such patients, if repeat biopsy patient is not fit for repeat biopsy, in such cases we can consider for ctDNA testing and biomarker testing on this blood sample. And also useful for monitoring prognosis, response to treatment, and progression or relapse, identify relapse of disease. It overcomes some major challenges associated with tissue testing, like it is a minimally invasive procedure, and sometimes tumor may have heterogeneity. So ctDNA in bloodstream is comprised of DNA from all tumor sources. So by this we can overcome this heterogeneity, and we can also identify tumor changes over time. But ctDNA testing may never replace tissue biopsy entirely, but it is useful in particular situations, specific situations. And also, it is useful to detect MRD after surgery in early stage resectable lung cancer. When we see data from this TRACES study, in the study, 24 early stage NSCLC patients followed longitudinally after resection. In this study, 93% of patients with disease recurrence were MRD positive, whereas 90% of patients without recurrence were MRD negative. So with this ctDNA profiling, circulating tumor DNA profiling, we will be able to identify patients who are having worse prognosis and who will relapse early. So, but additional studies to assess this ctDNA monitoring are needed and are ongoing. Then what are the advantages and disadvantages with this liquid biopsy compared to tumor tissue biopsy? As I said, only it is a simple blood test and minimally invasive procedure. And also it is more reflective of tumor genomic landscape. It overcomes the shortcomings of tumor heterogeneity. Then what are the disadvantages? With liquid biopsy, we are not able to identify the histological subtype, and also very sensitive methods are required to analyze this ctDNA, and no guidelines exist regarding the recommended performance characteristics of liquid biopsies, and less evidence is there for liquid biopsy compared to evidence for tissue biopsy. These are the disadvantages. So previously we used to do single marker testing, first EGFR, ALK. If it is negative, then we go for ALK, and after that other molecular markers testing. But compared to this sequential testing, doing a broad panel NGS would be better in many ways. Then what are the advantages? If only one or few molecular markers are needed, then single marker testing will be useful. But sometimes initial markers may come negative. We need more and more testings for these targeted alterations. If many molecular markers are we consider testing many molecular markers, then the overall cost of NGS and turnaround time will be less for NGS compared to sequential single testing. These markers I have already discussed: EGFR, ALK, ROS1. These are the various markers. Compared to coming to EGFR mutation testing, as I have discussed, FFPA sections or alcohol fixed specimens have to be used. Cell blocks are also suitable. And coming to the site of biopsy, whether we should go for biopsy from primary site or metastatic site. There are many studies which have compared concordance rates between these two sites, but discordance between these EGFR mutation status between these two sites are very rare. We can consider biopsy from either site. Then what is the role of EGFR mutation testing in early lung cancer? For early lung cancer patients also, we should go for EGFR mutation testing, as recently gosematinib has been approved in adjuvant setup based on the results of ADARA study from stage 1B to 3S. So for these patients, we should consider for EGFR mutation testing either on the biopsy specimen or on the surgical specimen. And what are the advantages of NGS over PCR? So when we compare NGS and PCR in one study, 48.6% of EGFR exon 20 insertion mutations identified via NGS are missed by PCR. And out of the 17 most common exon 20 insertion mutations, only 4 can be identified via PCR. So NGS is better compared to PCR. Coming to alt rearrangements, as I said, it is more common in non-smokers, and we see in around 3 to 7% of patients, and it can be tested with both IHC and FISH. FISH IHC is 93 to 100% sensitive and specific compared to FISH, but IHC is less expensive, hence it is more widely adopted. ROS1 rearrangement. ROS1 rearrangement also can be tested with IHC and FISH, but FISH is the gold standard. Even if results with IHC come positive, then that has to be confirmed with FISH again. KRAS mutations. Previously, we didn't have any targetable drugs for KRAS mutations, but recently sotorasib has been approved in KRAS G12C mutation, which constitutes around half of these KRAS mutations. Overall, KRAS mutations are seen in 20 to 25% of lung adenocarcinomas. Out of this, approximately half are G12C mutation, but sotorasib is approved only in second line, not in first line. KRAS mutations are more common in smokers. And this is another mutation which is commonly seen in smokers. In BRAF mutation, there are two types, V600E and non-V600E. But V600E is more common, and also targetable drugs are there for only V600E mutations. For non-V600 mutations, there are no targeted therapies approved. Currently approved therapies are dabrafenib plus trametinib combination was approved.
Sorry, Pravina, please stick to the time. You already
Okay.
crossed. Please wind up quickly.
Okay, ma'am. Other alterations are MET exon 14 skipping mutations and MET amplifications. These are the testing methods. As I said, RNA-based NGS is most sensitive compared to DNA-based NGS, especially for fusions and exon 14 skip mutation. Other alterations are RET rearrangements seen in 1 to 2% of cases. For RET alterations also, NGS is the standard. NTRK fusions are seen in very less than 1% of patients. Entrectinib and larotrectinib are approved for NTRK fusions. HER2 mutations, they are mostly exon 20 inframe insertions. Recently, FAM trastuzumab deruxtecan has been approved for HER2 mutation. This is the 2022 treatment paradigm. These are the various biomarkers. EGFR, we know various TKIs are there, first generation, second generation, third generation. Recently, for exon 20 insertions, envatinib and mobocertinib were approved for second line. Alt mutations, we know eletinib, brigatinib, etc. For ROS1, crizotinib or entrectinib are approved. BRAF, dabrafenib and trametinib combination. NTRK, larotrectinib, entrectinib. RET, sulfatinib or pralatinib. MET exon 14 mutations, capmatinib or tepotinib, and as I said, sotorasib for KRAS mutations. This is the PDL1. These are the various antibodies and platforms we use for PDL1 testing. So finally, these are the various biomarkers we should test prior to considering taking treatment decisions for non-small cell advanced non-squamous non-small cell lung cancers. NGS is the standard technique. These I have already discussed. Thank you.
Thank you, Pravina. It's extensive. Next, the talk will be by Dr. Rajni Priya. She's a consultant medical oncologist and pediatric oncologist from Mahatma Gandhi Cancer Hospital. She'll be talking on the role of bevacizumab in the management of lung cancer. Dr. Rajni. I hope Dr. Rajni has joined.
Ma'am, I joined, ma'am.
Yes, please, Rajni, carry on.
Ma'am, actually, I'm share screen. Okay. Sammy, wait. Ma'am, you're able to see my screen, ma'am?
Yes, your screen is visible.
Yes. So, thank you, ma'am. Thank you for the wonderful opportunity. So today I'll be talking on the role of bevacizumab in advanced non-small cell lung cancer. So these slides have already been covered by Dr. Praveena ma'am. So lung cancer is the second most common cancer in males and fourth common cancer overall. So we have moved a lot. We have advanced a lot in the treatment of lung cancer. So almost 50% of the patients with advanced non-small cell lung cancer have biomarkers, and we have many more and more targeted therapies being available. So in the last 2 decades, we have seen a lot of advance in the management. So we have started in 2000, that is 2 decades back, with the use of platinum-based chemotherapy. So in 2006, bevacizumab, in addition with chemotherapy, has shown to have improved survival and made its way into the treatment armamentarium of lung cancer. And then we moved to identify the targets and targeted therapies. And now we are in the era of immunotherapy, especially in patients who are driver negative. So we all know that angiogenesis, which is an important hallmark of cancer, and targeting angiogenesis with a VEGF targeted therapy had improved survival in many cancer, as so in the lung cancer. So this, based on the existing data, so VEGF, this is a graph showing patients with high microvessel density and high VEGF factors have shown to have poor survival compared to patients with low levels. This indicates that VEGF predicts poor survival in patients with lung cancers. So this is a treatment algorithm for patients with driver negative advanced non-small cell lung cancers. So the patients, based on the patient's performance status, symptomatic burden, and the histology. So for patients with non-squamous histology, we have to see the PD-L1 expression. PD-L1 expression, if it's more than or equal to 50%, we can go for immunotherapy. For patients with less than 50% PD-L1 expression, immunotherapy or immunotherapy alone or chemotherapy in combination with bevacizumab can be tried based on the eligibility for the bevacizumab. So today I'll be discussing the role of bevacizumab under the following headings. So first is a role of bevacizumab. What is the role of bevacizumab in combination with a chemotherapy? So this is a ECOG 4599 trial, which is a phase 3 trial in advanced non-small cell lung cancer patients, where they're randomized into chemotherapy versus chemotherapy plus bevacizumab. The dose given here is 15 mg per kg. All patients with brain metastasis and hemoptysis were excluded from the trial. So the baseline characteristics were well matched between the two arms. So these are Kleppel curves, which clearly shows that addition of bevacizumab had resulted in an improvement of 2.2 months survival, which is statistically significant. So the adverse events of addition of bevacizumab to chemotherapy, we all are well aware of the adverse events. That is a hemorrhage, hypertension, proteinuria, headache, rash, neutropenia, and thrombocytopenia. So which are statistically significant and increased in bevacizumab arm. So this is other trial, that is a AVAIL trial, where advanced non-small cell lung cancer patients, non-squamous histology, they were randomized to either placebo versus bevacizumab at a dose of 7.5 mg per kg or 15 mg per kg. So if you can see, addition of bevacizumab compared to at a dose of 7.5 mg had resulted in improved PFS. And 15 mg per kg has also shown to have improved PFS compared to placebo. But when you can take the survival graphs, there is no difference with the addition of bevacizumab to chemotherapy. So in this AVAIL trial, there is only PFS benefit and there is no overall survival benefit. So coming to the adverse events, there is no much increase in the adverse events with the use of higher doses of bevacizumab. And these are the meta-analysis of all the randomized trials, almost 6 randomized trials. Meta-analysis had finally concluded that addition of bevacizumab to chemotherapy had shown to have improved survival. So this is in the era of, this is before immunotherapy, where bevacizumab had a role in management of advanced non-small cell lung cancer patients of non-squamous histology, where addition of bevacizumab to platinum-based chemotherapy had resulted in improved survival. So next is the role of bevacizumab as maintenance therapy in non-small cell lung cancer. So this is a EVAPORAL trial where all advanced non-small cell lung cancer patients post 4 cycles of chemotherapy were randomized to maintenance with either bevacizumab plus pemetrexed or bevacizumab alone. The primary endpoint of the study is PFS. So the baseline characteristics were well matched, and if you can see in the curves are clearly well separated. The PFS with the use of bevacizumab alone is 6.6 months, and with the combination of bev plus pem, it's 10.2 months, which is statistically significant. But if you take the overall survival, the numbers are high. There is numerical difference with the use of PEM maintenance, that is 19.8 months compared to BEV alone, that is 15 months, but it's not statistically significant. So they had concluded that addition of PEM to BEV maintenance had not resulted in any statistical improvement in the overall survival. BEV plus PEM combination compared to BEV alone had resulted in PFS benefit only. So this clearly shows that there is only PFS benefit, but there is no improvement in the overall survival with the combination of BEV and PEM. So BEV alone as maintenance therapy post chemotherapy plus BEV chemotherapy has shown to have is shown to be like almost equal to your combination with the bevacizumab or pemetrexed, because there is no survival difference. So other trial, Point Break trial, this is also a phase 3 trial where patients were treated with chemotherapy, either PEM carbo or paclitaxel and carboplatin followed by BEV maintenance versus BEV plus pemetrexed maintenance. Even in this Point Break trial, there is no overall survival difference. So next is a role of maintenance BEV with combination with erlotinib. So this is in the driver negative patients. So previously, before, for driver negative patients, after chemotherapy, they were kept on erlotinib maintenance. So even they had tried combining bevacizumab plus erlotinib as maintenance post chemotherapy. So even this has shown to have a PFS benefit, but there is no overall survival with this combination, but with increased toxicity. So this is not a option in management of the treatment of advanced non-small cell lung cancer. Coming to the role of bevacizumab along with immunotherapy in advanced non-small cell lung cancer. So now that we are in the era of the immunotherapy, so even along with immunotherapy, BEV has been tried, and the trial is a IM power 150. So all the patients with stage 4 patients were randomized to either atezolizumab plus paclicarbo or atezolizumab, bevacizumab, paclicarbo, or bevacizumab and paclitaxel, followed by maintenance with atezolizumab alone or atezolizumab plus bevacizumab maintenance or bevacizumab maintenance alone. So these are the baseline characteristics. If you can see, this study included even patients with the driver mutation positive. So almost 13% of the patients were positive for driver mutations. So this trial holds good even for patients who are driver positive also. So for patients who progress after targeted therapy, this trial holds good. And these patients included irrespective of the PD-L1 expression. So IM power 150 trial results, the updated PFS in the ITT wild that is driver negative patients, it has shown that the overall the PFS the curves are widely separated with a hazard ratios of 0.59, which is statistically significant. So even overall survival, there is statistically significant improvement in the overall survival with the use of atezolizumab, paclitaxel, carboplatin, and BEV compared to BEV plus chemotherapy. So this is ABCP versus BEV plus chemotherapy. So it is shown to be superior in irrespective of the PD-L1 expression, irrespective of the mutational status. So we all know the adverse events with the use of the immunotherapy. They are the immune-related adverse events. So if you can see, the adverse events are immune-related adverse events are high with the use of immunotherapy, but the grade 3-4 toxicities are not very high. They are less than 5% if you can see in the arms containing the immunotherapy. So finally they concluded that in patients with untreated advanced non-squamous non-small cell lung cancer, addition of atezolizumab to chemotherapy plus bevacizumab, that is ABCP, had resulted in improved PFS, overall survival, irrespective of the PD-L1 expression and the mutational status, and without any increase in the risk of immune-related adverse events. Coming to the role of bevacizumab in combination with EGFR therapy in EGFR mutation positive patients. So erlotinib plus bevacizumab in driver positive mutation has shown to have improved PFS benefit, but there is no overall survival benefit. So if you can see the PFS benefit in exon 19 deletion, it is 16 months versus 12 months. In exon 20 patients also, there is very good PFS benefit. Usually exon 21 patients, they do badly, but with the addition of erlotinib and bevacizumab, it's almost 17 months versus 13 months. So there is improved PFS benefit with the use of this combination. But now that in the era of osimertinib, which is an oral form of therapy, which is a more potent with better safety profile and with good CNS penetration, maybe this takes a back step. So finally, to conclude, personalized therapy is a standard of care in advanced non-small cell lung cancer. Immunotherapy has changed the treatment landscape of biomarker negative advanced non-small cell lung cancer. Chemotherapy or during maintenance had significantly improved outcomes in driver mutation negative non-small cell lung cancer. Combination chemoimmunotherapy with bevacizumab also significantly improved outcomes and is a treatment option in advanced non-small cell lung cancer patients, irrespective of the driver mutation status. Thank you.
Thank you, Dr. Ashwini, for your presentation. That was good. And next, we'll have the panel discussion. I would like to invite the moderator, Dr. Shaini Reddy. She is a medical oncologist from Omega Hospital, Hyderabad. Dr. Shaini, can you invite all your panelists?
Good evening, everyone. Thank you for the opportunity. I'd like to thank AstraZeneca and Dr. Mayalakshmi Madam, the program director, for giving us this opportunity. I would like to invite my panelists. Dr. Rajni is a consultant medical and pediatric oncologist at Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. Dr. Rajni, I hope you are available, right?
Yes, ma'am.
Am I audible? Okay. Okay. Dr. Praveena Vona is a consultant medical oncologist at Mahatma Gandhi Cancer Hospital and Research Institute, Vizag. So, Praveena, are you available?
Yes, available.
Dr. Lakshmi Deepti is a consultant medical oncologist at Surya Global Multi-Specialty Hospital, Kakinada. Dr. Lakshmi? Dr. Lakshmi Deepti, are you with us? Okay. Dr. Rajni is an assistant. Dr. Rachna is an assistant professor at Nizam's Institute of Medical Sciences, Hyderabad. Dr. Rachna, are you available?
Yes, I am there, Dr. Shen.
Okay. So, is Dr. Lakshmi Deepti didn't log in or any issue?
No, ma'am. She will be logging soon, ma'am. She is logged in.
Okay. Dr. Anu Susan George is a medical oncologist at Lakeshore Hospital, Kochi. Dr. Anu Susan, are you available?
I'm there, ma'am.
Dr. Kripa Bajaj is a consultant medical oncologist at Indo-American Cancer Hospital and Research Center, Hyderabad. Dr. Kripa, are you available?
Yeah, ma'am. I'm here, ma'am.
Okay. Dr. Mahati is a consultant medical oncologist at Omega Hospital in AP. Dr. Mahati, are you available?
Yeah, ma'am. I'm here.
Okay. Thank you, everyone. Thank you for joining on time. So we shall start with the panel discussion. Are my slides visible?
Yes,
Yeah,
ma'am, very much.
So we are here to discuss the different case scenarios when treating EGFR mutant NSCLC. So we'll be discussing briefly about EGFR mutant patients with high PD-L1 expression, and we'll also be discussing about patients who have
There is an
oligoproliferation.
echo of your voice, ma'am. Can you did you device? I mean, did you log with 2 devices? But can you please check once? There is a lot of echoing. Is there?
Is it me?
Yeah, ma'am. Your voice is double audible actually.
Okay, I didn't log in from 2 devices. How is it now?
Yeah, now it is clear, ma'am.
Okay, fine. So we are here to discuss different case scenarios in treating EGFR mutant non-small cell lung cancer patients. So one is the EGFR mutation with high PD-L1 expression, and the second case scenario we'll be discussing is about patients with oligoprogression, and the third scenario will be how to treat patients with brain metastasis. So coming to EGFR mutant patients with high PD-L1 expression, here we have a 65-year-old male patient who is a non-smoker and came with the complaints of cough and pleuritic chest pain since 1 month. CT chest was done, which was showing a left lower lobe mass, which was 5.5 centimeter and invading the pleural. There was left pleural thickening and effusion. And essentially adenocarcinoma lung stage 4, and TTF1 and abscin was positive, and the PD-L1 expression was 95%. And when the oncogenic driver testing was done, EGFR exon 19 deletion was detected. So, Dr. Rajni, what routine molecular markers do you look for in non-small cell lung cancer patients?
We go with test NGS, ma'am. These days we have abandoned the individual EGFR all testing, so we go directly with the limited NGS panel testing. For 9 gene or 12 genes where targeted therapies are available. So NGS is what I routinely do, followed by PD-L1 testing by IHC. So these tests I would like to get done, ma'am.
Okay, that's really nice that you are able to do NGS at your center. I think Dr. Praveena is also at the same place. So are you doing NGS as well, Dr. Praveena?
Yes, Dr. Shine. If patient is affordable, I would prefer NGS. If patient is not preferable, then I would go for only EGFR and ALK testing.
Yes. Okay.
Fine. For like government scheme patients.
Okay, fine. I hope is Dr. Lakshmi available, or should I go with the next?
Ma'am, I'm available, ma'am. I'm available.
Okay, welcome, Lakshmi. So, how soon are you getting the PD-L1 IHC report at your place? How much time is it taking approximately?
1 week.
1 week. Okay. And
Yes.
how about the NGS reports? Are you sending
NGS,
for NGS?
we are
or
not
you're
able to
looking
do
for
at our
individual
center,
markers?
madam, because of the affordability issue.
Okay, fine. So you're looking at individual markers. So how much time
Yes.
is that taking at your place?
1 week.
Okay. Both of them 1 week?
Yes, ma'am.
PD-L1 IHC and
Yes, everything is being
individual
sent
markers.
outside, so it is taking 1 week, ma'am.
Okay, good. Dr. Rachna?
Yeah, at our center we are sending NGS, and the PDL1s, if you are sending along with the NGS, the PDL1 report we are getting in around 5 days.
5 days,
And
yeah. Okay.
yeah, and if it is the NGS, then we are getting it by around 7 to 10 days is the turnaround time for the NGS. If we are doing the PDL1 within our center, it will be around 2 to 3 days time we'll get the PDL1 IHC.
Okay.
Only
So
we are
that's
doing the
really
PDL1
nice.
at all.
Okay, that's really nice. Dr. Anu Susan, how about the situation at your place?
Preferably we send for an NGS, ma'am, if they're affordable, because we have those coupons which are allow us to do it at a subsidized rate. So usually turnaround time is around 7 to 10 days.
Okay, for NGS. And for the PDL1 IHC?
About the same, about 7 to 10 days. We don't do it in-house. We are again outsourcing it. So it takes about 7 to 10 days.
7 days. Okay. So would you wait for the EGFR report? Like most of them, some of you have said that you are getting the PDL1 report maybe in 3 to 5 days, whereas NGS, I think it's going to take a minimum of 10 to 14 days. At least in our place, it's taking around 10 to 14 days for NGS. So we all by now come to the conclusion that the PDL1 IHC report is available much earlier than our NGS reports, right? So if the patient's PDL1 is high, do you wait for the EGFR report? Dr. Kripa Bajaj?
Yeah, I'll definitely wait for the EGFR, the NGS report or EGFR RT-PCR ALK report, because if driver is there, acting on PD-L1 doesn't make any sense because it's not going to get a response, ma'am.
Okay, that's really nice. And if the patient is symptomatic, your patient is symptomatic, he had this pleural effusion, is breathless
Then
and
I will
all.
give only chemotherapy,
And,
but not
okay.
adding immunotherapy is not an option given to a patient.
Okay, fine. Dr. Mahati, what would you do if the patient is symptomatic and the PDL1 is high, your EGFR is still awaited? What would you do?
I will go ahead with chemotherapy in that setting.
Okay, so you don't want to add any immunotherapy because PDL1 is high?
No, no, no. I'll wait for the EGFR.
You want to wait for the EGFR report. Okay. So that's what we all do most of the time. So EGFR mutation and PD-L1 status are the two strong markers for deciding the treatment options and improving outcomes in metastatic NSCLC. So which one should we give priority to? So, we should, in this study, they have seen whether the efficacy of osimertinib is affected in patients with high PD-L1. So in this, they have enrolled patients with PD-L1 more than 1%, less than 1%, and patients with unknown PD-L1 status. I think my voice is echoing in between. Hello. Are you able to hear me?
Yes, we can hear you.
Okay, fine. So the median PFS in patients with PD-L1 expression more than 1% was 18.4 months. In patients with PD-L1 less than 1%, the median PFS was 18.9 months. And in patients whose PD-L1 status was unknown, the PFS was 19.1 months. So essentially, the response to osimertinib was independent of the PD-L1 status. So also, there were trials in which they have seen whether the PD-L1 inhibitors have good response in patients with EGFR mutation positivity. So in about a couple of 3 to 4 trials, they have seen that there is no overall survival benefit, or in some of the trials there is no progression-free survival benefit also. When PD-L1 inhibitors were administered in patients with EGFR mutations. So in fact, in some trials, there was inferior clinical efficacy with the PD-L1 inhibitors in EGFR mutated NSCLC patients. So NCCN guidelines also recommend that although the PD-L1 expression can be elevated in patients with an oncogenic driver, targeted therapy for the oncogenic driver should take precedence over treatment with the immune checkpoint inhibitor. So the ASCO 2022 guidelines also state the same for patients with EGFR mutation. Ideally, we should start with the EGFR TKA rather than starting with a single agent immunotherapy for patients who have high PD-L1. So coming to the next scenario of oligoprogression. We have a 44-year-old female who is a non-smoker diagnosed to have stage 4 NSCLC with EGFR exon 19 deletion, and she was treated with osimertinib. There was near complete response, and there was progressive disease after 18 months. So on surveillance scan, there were 2 new metastatic bone lesions. So Rajni, what will be your next step? Dr. Rajni?
Yes, ma'am.
What will be your next step?
So actually already the patient is on osimertinib. So I will not go for any repeat biopsy, ma'am. Maybe if the patient is on any first generation or second generation TK, maybe would go for either liquid biopsy for T790M, but the patient is on osimertinib. So this is an oligoprogression and the patient is not symptomatic of the primary, then we can go with the continuing of the osimertinib and treat the bone lesions with SBRT.
Okay. So Dr. Praveena, do you agree with Dr. Rajni's view? She doesn't want to do a biopsy. Dr. Praveena, are you there?
Yes, Dr. Shaini, I would agree with Dr. Rajni. I would like to go with SBRT for 2 new bone lesions and continue osimertinib.
Okay, fine. So Dr. Lakshmi, do you differ in, anyone differs in opinion with Dr. Rajni and Dr. Praveena?
Yes,
does anyone want to get biopsy done?
Yes, ma'am. There is, because it's only 2 metastatic and that also only bone lesions. I would agree with Rajni, ma'am.
Okay. Do any of the other panel members differ in any of the opinions? Does anyone want to get a biopsy done before proceeding with next therapy, or?
Dr. Shaini, yes, though biopsy may not be possible from the bone lesions.
Bone lesion. Huh.
Yeah, but I would try to send the liquid biopsy for NGS if it is not done upfront.
Yes. Huh.
So that's what I would like to do. Though the treatment may not change, I would continue to do SBRT and continue with osimertinib because the patient is asymptomatic. But still, I would like to send the liquid biopsy to look for the MET mutations if they're seen.
If the progression was at in the lung, if there is a metastatic lesion in the lung, You still don't want to do the biopsy? You want to proceed? You want to do a metastasectomy, proceed,
No,
or
no.
give
If
RT
there is
and
a
proceed?
accessible lesion, I would prefer to do a tissue biopsy also, because
Yeah.
there can be a histological transformation.
Yes.
So,
So these
as
are
it
the
is a
things
bone
which
lesion in this case, so it may not be easily possible to do a
Yeah.
histological diagnosis. So I would
Yeah.
prefer a liquid biopsy.
Yeah, so T790M is not the only thing which we look when the patient progresses. There can be histological transformation also. There can be other mutations too. So since this is a bone lesion, yes, I agree that it's difficult to biopsy, and then the recalcification process, and it's difficult. So maybe for this patient, we can skip the biopsy part and go ahead with radiating the bone lesions.
Post osimertinib progression, like what targeted therapies we have, like to which we get in NGS?
There can be MET mutations, right?
But
And there can be histological transformation to small cell lung cancer.
That's what that we have to go for biopsy.
Biopsy only, yes.
Also, if you
And
don't
also
have NGS
C797S mutation, we can identify with liquid biopsy.
and if you have not done an NGS in the upfront, we might miss other driver mutations also, which might be there. Might be 2 driver mutations also.
So how frequently do you get like other mutations? Like initially it was not present, but on NGS progression, you get some ALK mutation and all any other mutation where you can use any targeted therapy.
See, it's not like we are doing
upfront it is
NGS
not done.
upfront for all patients, right? We might have done a limited panel upfront. For those set of patients, especially on progression, liquid biopsy might be more helpful because you might be getting additional information.
Yeah, broad panel. Yes. Okay, ma'am.
So I think we answered all these questions. So coming to the treatment, Dr. Anu Susan, what do you want to do? You want to continue the TKI? You want to do chemotherapy and continue the TKI, or you want to do a local ablative therapy and continue the TKI?
In this particular patient, I'll do a local ablative therapy, probably SBRT to the bone lesions, and then continue osimertinib if there are no other mutations that we have detected on the liquid biopsy.
So this patient was treated with local stereotactic body radiotherapy for the bone lesion, and osimertinib was continued for another 8 months. After that, patient had progression with multiple lesions. So I think most of us have come across cases of oligoprogression. If there's any interesting case, you can discuss, or shall we proceed with the next slide? Anyone is interested in discussing any case of oligoprogression, which is interesting?
No, Dr. Cheney.
Okay, looks like a no. So we'll proceed with the next slide. So this is a study in which out of 118 patients who were treated with osimertinib, there was in 76% of the patients who had progression, and osimertinib was continued in 47 cases with a median second PFS of 12.6 months. So also the continuation of osimertinib beyond progression was associated with longer overall survival compared to discontinuation of osimertinib. The survival was 11.2 months in patients who continued osimertinib versus 6.1 months in patients who discontinued osimertinib beyond progression. So the NCCN guidelines also state that if there is progression on osimertinib and if it's an asymptomatic progression, we can consider for definitive local therapy and continue osimertinib. If the patient is symptomatic and if there is a brain lesion, we can still consider a definitive local therapy and continue osimertinib. And if there is systemic progression and if there are multiple lesions, we can consider for systemic therapy. Coming to the next scenario of a patient with CNS metastasis, we have a 53-year-old patient who relapsed while being on chemotherapy for stage 3A. And the repeat scans revealed that there is a pretracheal nodal hypermetabolism, and the MRI, the patient was found to have brain mets with surrounding edema. Osimertinib was started in this patient initially at a dose of 80 mg. And patient complained of ataxia, which worsened significantly in the subsequent days. And so she was scheduled for craniotomy and tumor resection the following week. So in this patient with symptomatic brain mets, what is the line of treatment? Dr. Mahati, would you like to take this question?
Hello.
Yeah, Dr. Mahati.
For a patient with symptomatic brain
CNS,
mets,
yeah. What would you like to do? Upfront symptomatic CNS metastasis.
driver mutation.
EGFR mutation is positive. We are discussing only those cases, right?
So the patient with symptomatic brain mets, even with EGFR mutation positive, I will go for local therapy first for brain mets, followed by EGFR TKI. But if the patients are not that symptomatic and affordable for osimertinib, I will try osimertinib first.
Okay. So how much symptomatic is what you want to, your division criteria will be, right?
Yeah.
That's what you wanted to say, right?
Yeah. Usually, if the patients are symptomatic with with epilepsy or herniation or at risk of herniation, usually that is the indications for surgery at risk of herniation and massive edema. In such patients, it is local therapy. In such patients, local therapy first followed by systemic. Otherwise, if not, then I would rather go for osimertinib upfront.
Okay. Dr. Kripa Bajaj, what is your opinion on this?
Yeah, ma'am. I mean, I agree with Dr. Mahathi. If patient is asymptomatic, I do start with osmot 80 mg dose. Here, the patient has progressed on 80 mg dose and became symptomatic. For him, we have to address the local lesion as well. And after completion of the treatment, I'll increase the dose, develop the dose to 160 mg after some time. Like after once the edema, everything got subsided, maybe a 5 days gap, I'll increase the dose to 160 mg.
Okay. So Dr. Anu Susan George, what is your opinion? Patient with symptomatic brain mets, do you want to give local therapy like radiation first and then start the patient on osimertinib? Or you just want to start the patient on osimertinib and do close monitoring?
No, if the patient is symptomatic brain mets, I'll start give the SBR either SRS, if depending upon the number of lesions, or whole brain RT, and start on osimertinib because if the patient is symptomatic. Otherwise, asymptomatic, start with osimertinib.
Okay. Dr. Rachna, you want to start symptomatic patient on RT and then go to osimertinib or start the TKA directly?
I would start, the patient is symptomatic, we would go for RT and simultaneously start with osimertinib if it is an upfront CNS metastasis. If it is progression on osimertinib, like Dr. Kripa Bajaj has said, I would increase the dose of osimertinib from 80 to 160 mg.
Okay. Dr. Rajni and Dr. Praveena, do you agree that for symptomatic patients, you want to give radiation first or surgery first and then go for osimertinib? Or are you trying just the TKI initially and then close monitoring of the patients?
No, ma'am. I agree with the other panelists. Local therapy followed along with the osimertinib, starting with osimertinib.
So on day 15 of starting osimertinib and corticosteroids, our patient had resolution of symptoms and a pre-surgery MRI showed a decrease in the lesion. She was initially planned for surgery after a week, but then after starting osimertinib and steroids, she was symptomatically better and MRI showed a decrease in the lesion. So if the PET scan is suggestive of brain mets, are you all doing a confirmatory brain MRI? Again?
Yes,
we are doing that now.
Yes, ma'am.
Okay. So Dr. Rajni and Dr. Praveena, are you doing brain MRI in all patients with stage 4 NSCLC?
Not for all patients. For patients for whom we are planning for definitive curative treatments like lobectomy, for such patients, I think it would be better to do MRI and then proceed for such procedures. Actually, it is recommended from stage 2 onwards.
Yeah. So
according to guidelines.
Yes,
okay.
ma'am.
At your center, you are not doing routinely in all patients.
For symptomatic patients and for driving.
For symptomatic brain, already showing PET scan is showing multiple brain metastasis and symptomatic. For such patients, I think we can go for whole brain RT directly without doing brain MRI. But for patients having limited brain mets, needing SRS or SRT, such patients we should go for brain MRI followed by SRS or SRT. That is useful for planning also.
Okay. Dr. Lakshmi Deepti, are you doing brain MRI in all your patients?
No, ma'am, we are not doing in all our patients. We are doing only in symptomatic cases.
Dr. Rachna, how is it at your place?
It's similar to what Dr. Praveena was saying. If the PET-CT is showing multiple brain metastasis, we are not doing any MRI. If the patient, we are planning for a limited RT like SRS, then we would go for MRI, which could also help in planning.
So patient is not symptomatic and PET-CT is normal, like not showing any uptake in the brain. You're not doing MRI as a routine, right?
Yes, we are not doing MRI as a routine.
Okay, Dr. Anu Susan.
I agree with the other panelists, ma'am. If the patient is symptomatic and if the PET is already showing multiple lesions, we don't go for another confirmatory brain MRI.
Okay. Okay, and Dr. Mahati?
If the PET is suggestive of brain mets, that's fine. We won't do any further brain MRI. Only if symptomatic patients will definitely
PET is
do
negative,
brain MRI.
patient is asymptomatic. Are you getting a brain MRI done?
PET is negative, patient is asymptomatic, no brain MRI.
Okay, so you're proceeding directly with therapy. Okay, fine. Yeah. So this is a study in which they have enrolled patients only with asymptomatic brain mets. This is an open label 3-arm phase 2 pilot study. In this, there were 3 arms in the study. Patients were either treatment naive or they were previously treated with a EGFR TKA and they were T790M positive. And the arm C were T790M negative patients. In these patients with asymptomatic brain mets, the median progression-free survival was 11.8 months. So the authors concluded that osimertinib demonstrated high efficacy on brain metastasis and all the trial arms displayed a significant decrease in the number and the diameter of the target lesions. We all know that osimertinib has a better CNS penetration and it acts well even in patients with CNS metastasis. So this is a systematic review and meta-analysis of 15 studies which were done to assess the effectiveness and safety of osimertinib for patients with intracranial metastatic disease. In this meta-analysis, the CNS overall response rate was 64% and the disease control rate was 90%. So I think we discussed this doing MRI in asymptomatic patients. How are you all treating patients with asymptomatic CNS metastasis? EGFR mutation positive and asymptomatic CNS metastasis. Dr. Mahati, what would you like to do?
So first option would be osimertinib.
Okay. If patient is not affordable for osimertinib, what would you like to do?
Then it should be first generation, second generation TKIs we are going for. Still, if it is like very low burden asymptomatic, I would rather wait and start off with the TKI. Otherwise, preferably to go with RT followed by first and second generation TKIs.
No chemotherapy?
No.
Okay. Dr. Kripa Bajaj?
Yeah, I agree with Dr. Mahati. If patient is affordable, patient with serious metastasis, I'll start with osimertinib. I mean, even irrespective of it, like if I start with osimertinib, there's a good CNS free metastasis-free survival is there. The patient is like not on osimertinib and few mets are there. Even very few metastases are there, then it's okay to start. Dacomitinib, I don't think so. Like it's so easily available and so easily tolerable to our population. Yeah. So I'll start with first generation TK. Once like any progression is there, like then I'll hold a WRT I do offer. The patient is having multiple brain lesions, symptomatic, WRT followed by first generation TK. That's what our stand currently is.
Okay, do you want to do chemotherapy plus TKI? I think you're practicing chemo plus TKI at your center. So is this a subgroup of patients whom you're interested in doing chemo plus TKI?
Yes, because carboplatin has, carboplatin, I do agree with you, ma'am. Carboplatin has a decent penetration to the brain. So there's a good OS benefit is also there by adding in this subgroup if we do this combination significantly. So fit patients we are offering, but most of the times it's like 50, 55 plus above and who are not so great, not in great PS. So in them we do follow this WRT followed by TK or TK alone like followed by WRT. We do sequence as per the disease burden.
Okay, thank you. Dr. Anu Susan, like what would you like to do? You want to give, if patient is affordable, all of us want to go ahead with osimertinib. If patient is unaffordable, what would you like to do? Other generation TKAs or chemo plus TKA or whole brain radiation? Or what is it?
Asymptomatic, I would go for whole brain radiation and then the first generation
asymptomatic?
Asymptomatic, I'll probably go for a first generation TKI, preferably erlotinib. Dacomitinib, as the previous speaker said, is not so easily available. It's costlier also. So I would prefer use erlotinib.
Yeah, how do you see the rash percentage, and are you able to manage the rash well with erlotinib?
Rash is actually, yeah, compared to gefitinib, it has got more rash, but I've not had very problematic cases. I'm able to use it fairly okay. My patients are tolerating it.
Okay. Dr. Rachna, what is your take on this?
Sorry, you're discussing about the
Treatment of
asymptomatic
asymptomatic CNS mets, yeah.
Yeah. So asymptomatic CNS metastasis, we are not addressing them with RT. But if the patient is not affordable for osimertinib, and if he is young and fit patient, would consider giving first generation TKI plus chemotherapy.
And that's what even we are following at our place. Patient is fit to receive chemotherapy, not affordable for osimertinib. Yes, we are combining TKI with chemotherapy, and I am not seeing like too much increased toxicities. Patients are able to tolerate fairly well. So that's what I wanted to know from others, whether they are doing this or just the other TKAs. So Dr. Rajni and Dr. Praveena, are you just starting with the TKA or chemo TKA or radiation, or how is it? Asymptomatic CNS metastasis?
For asymptomatic, we are not going with RT upfront. Patient is affordable, osimertinib, obviously. Patient is not affordable, chemo plus first generation TKI way better option.
Okay.
And one more option is we can consider pulse doses of erlotinib, but I have never tried that.
Yeah. Do any of you have any experience with the pulse dosing?
No, ma'am.
Okay, so that should be taken as a no. Everyone in silence. Okay, Dr. Lakshmi Deepti, what is your take on treatment of asymptomatic CNS metastasis?
In asymptomatic CNS mets, if the patient is young and fit, we are going with chemo and TKI, ma'am.
Yeah.
If the patient is not fit and if they're affordable for osimertinib. Otherwise, only TKI alone with brain RT.
Yeah, so after 4 cycles of chemo and TKI, patient has good response in the brain and in the periphery. You want to do maintenance PEM with the TKI or maintain just with the TKI?
Both, ma'am. Maintenance PEM with TKI.
Okay. So, Dr. Anu, Susan was, I'm not sure whether she wanted to give chemotherapy with TKI. Dr. Kripa Bajaj, I think you told that you wanted to do chemo with TKI, right?
Yes,
So,
ma'am. I do start with triplet.
yeah, after 4 cycles, if there's a good response, do you want to just continue the TKA or you want to give some maintenance chemo with TKA?
No, maintenance chemo with TK is followed, ma'am.
Okay, so maintenance chemo with TKA is what you do once
Yes.
there is a response. Okay. So these are the NCCN guidelines for therapy of patients with CNS metastasis, patients with brain metastasis and EGFR sensitizing mutation. We are going to treat with osimertinib, though the other generation TKIs are also available. In patients with leptomeningeal and spinal metastasis, maybe we need a higher dose of osimertinib. I'm really not sure if anyone has tried high dose in leptomeningeal and spine mets. Any experience with this?
No.
Has anyone tried the 160 mg dose in patients with leptomeningeal and spinal metastasis?
No,
Yes,
ma'am.
ma'am. Actually, we tried, ma'am. I mean, we do use it actually when leptomeningeal spine mets or any patient who progressed on 80 mg. We do increase to 160 mg because it requires like more CSF concentration.
Yeah.
Yeah.
How about the toxicity and others?
In toxicity, I don't see much toxicity, but transaminases is the one which we are significantly finding it. But that too, it's a manageable one. It's not so significantly, like to decrease dose or to defer the treatment like that.
Yeah. How often are you seeing the leptomeningeal and spine mets in EGFR?
It's not so often, ma'am. Like, but patient progressing on ATMG is like so frequently seen. But leptomeningeal spine mets, like I do say, like if I see the all 100 brain mets case, only like 3 or 4 will be like that.
Okay, so that ends our discussion. Thank you so much, everyone, for actively participating. I would like to hand over the next session to be continued by Dr. Meher Lakshmi, madam. Thank you, madam, for the opportunity.
Thank you, Dr. Shiny. And for the next topic, I'd like to invite Dr. Kripa Bajaj, consultant medical oncologist from Basavatarkam Cancer Hospital, Hyderabad. She'll be talking on the recent advances in the management of EGFR mutant non-small cell lung cancer. Dr. Kripa.
Yeah, ma'am. Can I share my screen? I can't share the screen because other participant is sharing still. And I would like to thank Mahalakshmi ma'am for giving this opportunity to participate as a panelist and speaker in the meantime. Thank you so much, ma'am, for the opportunity. Shiny ma'am, can you please like unshare your screen because I'm unable to share my screen?
Yeah, just a second. I'm doing that.
Yeah, sure. Is my screen visible now?
Yes, ma'am.
I hope I'm audible clearly, right?
Yes, ma'am. But yeah, now full screen it is.
Yeah. So now I'm going to discuss regarding the recent advance in the management of EGFR mutated NSLC. Most of them it is like discussion regarding metastatic NSLC. So understand the emerging first-line treatment landscape of target therapy EGFR mutation positive NSLC is the topic of discussion now. And all of us like repeatedly told osimertinib is the main drug like which to be used in the first-line management of metastatic NSLC. So what's the burden and what is the strategies we do follow? The few slides I didn't get, like maybe in the end of the talk, I do discuss regarding it, but initially I'm just going to cover the common topic that's the EGFR mutation and what's the first line thing like we are using it. So lung cancer is the second most common diagnosed cancer and NSLC is a major histological category. And without targeted therapy, the prior, like only just with chemotherapy, it's only just 4 to 5 months with only supportive care and only the 5-year survival is only 6% with historic cytotoxic chemotherapy. With the onset of immunotherapies and target therapy, the 5-year survival has significantly increased from 15 to 50%, which is like leap in the management of any cancer known. What are the most common types of NSLC we do see? What are the mutations we do see? As per the prior panel discussion and the previous biomarker, which was really well explained by all the speakers and panelists. So Asians have like a significant increase in EGFR mutation positivity as well as ALK positivity compared to the global population or non-Asian population. The incident rate of EGFR mutation among Indian population is approximately 28% to 23%. And when few centers like did their individual analysis, it went up to at least 35%. TMH data is having a 35%, and South also similar data was replicated by ADAR and few other institutions. So if you see, the predominant EGFR mutation is exon 19 and exon 21, which considers almost 80% of the EGFR mutations. So what the first generation, second generation, third generation EGFR TKs? All TKs are not equal and they have their own different mechanism of action as well as different toxicity profile. The first generation TKs are erlotinib, gefitinib. Second generation TKs afatinib, dacomitinib, and third generation is osimertinib. Osimertinib is the like most effective out of it. Like why it is so? It is not just irreversible binding like just like second generation TK. It's having a broader specificity and sensitivity as well as it's having a binding towards EGFR T790 mutated gene as well. And so this is a very effective drug amongst the all. And next irreversible target is the afatinib and dacomitinib. All of us like discussed before, afatinib and dacomitinib is not an easily tolerable drug. And dacomitinib, though it's having a CNS penetration, the tolerance to dacomitinib is not so great, be it diarrhea or rash. Afatinib now it's available in generic version, but like if you come into the spectrum of activity and tolerability, afatinib always scores low compared to the osimertinib. All of us are like really fans of this erlotinib gift because all of us are having a very good experience with this. So because it's so easily available, cheaply available, but it's a reversible one, inactive on T790 mutation. It's not so effective and efficacious compared to osimertinib. I'll discuss regarding the PFS and OS like subsequently. So these are the spectrum of trials like what address the first generation, second and third generation. Like the first generation, the groundbreaking trial in the management of lung cancer is IPASS trial. And for erlotinib, it's UTRAC trial and ENSURE trial. So the first generation TK, all the first generation trials, there is a good PFS benefit, but the OS benefit is not so significant compared to the chemo. So when coming to the second generation TK, so afatinib and dacomitinib are there, like which I'm going to discuss in detail later. And third generation TK, that's a osimertinib, it's having a both good PFS as well as OS benefit. So the first line treatment strategies in EGFR mutated NSLC, what's the best option? So what we usually see when managing the lung cancer in the first line, it's what is really important to us is PFS, ORR, that overall response rate, OS, are reduced to CNS metastasis good safety profile and toxicity, good QOL, prolonged time to first subsequent therapy. All these do play a major factor to us. Like some are really important to us depending on the patient we do see. So quality of life is one thing really all of us are concerned about, like PFS, OS, like it depends on the patient to patient, and CNS metastasis definitely free survival. All these are important, but QL definitely stands like out of all these to us when you want to choose one drug. So what is the PFS like benefit you do see in the second generation TK as well as third generation TK? Both are not equal. In the LuxLung 7 trial for afatinib versus gefitinib and Archer trials for dacotinib versus gefitinib, if you see the hazard ratio hazard ratios are like looking like decent, even the p-value is like decent in the dacotinib group. But when compared to the Flora trial, it is 18.9 versus 10.2. The immediate separation of curves is there. In dacotinib, there is initially the curves are not separated. Eventually, it got separated. The numbers at the immediate separation of curves showed that osimertinib is a very potent drug, which straight from the day one, it's very effective. So the lower frequency of early resistance to osimertinib as compared to early resistance to standard EGFR TKs of first-line therapy made the curves to separate very early. It has a highest PFS, that's 18.9, which is like not comparable with any second generation TKI. So what are the mutated group like exon 19? There is a for osimertinib 21.4 months is the PFS for exon 19 deletion. Comparable, it's not comparable like 16.5 and 12.7 months. It demonstrates the longest PFS regardless of the mutation type. So the PFS, like all the goals will be achieved. I'm not going to repeat this slide again. All these goals will be achieved with the osimertinib better. That's what I want to stand on it. What is the objective response rate? Like obviously the ORR, if you see the dacotinib, afatinib, and this one, it's 80%. It has shown the highest ORR, and median duration of response is also like decent enough compared to the dacotinib and afatinib. It is 80% ORR and duration of response is 17.2 months, which is like fairly well compared to other second generation TKI. And first generation, I'm not going to mention because it already scored back compared to second generation. So this also met. And coming to the OS, if you see the OS analysis in LuxLung 7, there was no significant difference in the OS with afatinib versus gefitinib. And in the second generation, the dacotinib, as overall were not statistically significant, the statistical significance of OS improvement could not be formally assessed. It was again like published by the lung oncology group that because of the hierarchical design strategy policy is there, so the OS cannot be commented on it, and because of the statistical analysis defect. And in the osimertinib, the Flora trial, there is significant improvement in OS got noted compared to the EGFR TK, the standard one. So 38.6 versus 31.8. So this is the current oncology group, the phase 3 Archer trial, just like we discussed before, the trial had a hierarchical stratified statistical design, and given that it did not meet the significance, the ORR p-value could not be given to OS. So that's why dacotinib OS can't be mentioned, commented in any trial mentioned. But dacotinib, like when it got released, the trial data got released, it was hailed as a very good potent drug, but compared to osimertinib, it didn't score well. So CNS activity, all of us like really stood with the osimertinib when coming to the brain metastasis. So the median PFS, the CNS activity is 15.2 months. Archer trial, fortunately, though it is dacotinib is having a CNS penetration, the trial did not include the brain mets cases. It got excluded. Whereas in afatinib, though the brain mets cases got included, it's not having a significant CNS activity, and there is no difference compared to the gefitinib. Osimertinib may represent a clinically significant treatment option for patients with the EGFR mutated NSCLC and brain metastasis. So they're the same. Patient with CNS metastasis, there is a good PFS benefit is that it's 19.1 months compared to the standard TKI, and it demonstrates superior systemic PFS benefit regardless of CNS disease status. So almost half of the patients, this is regarding the preferable TK in the CNS metastasis. I'm not going to read the entire thing. It's osimertinib for sure. So this also got, there is a good CNS metastasis free survival as well as PFS with the CNS metastasis also there with osimertinib usage. What are the drug-related adverse events? If you see here, it's comparable. This almost like half of the adverse events compared to dacotinib. Dacotinib, if you see, it is 63% adverse events are there, got noted. Significant diarrhea and rash were detected. But in osimertinib, it is only 32%. It's very effective. If ever you want to compare one drug, it's dacotinib. So it's a very well tolerated drug. There is a good quality of life got noted in the FLORA trial. Only 4% frequency of dose reduction is there. It's considered to be very well tolerated at the recommended dose of 80 mg. So the adverse event linked to dose reduction of second generation TK like afatinib and dacomitinib are very frequent. Afatinib, almost all of us burn fingers with the full dosage usage. Significant diarrhea is there as well as skin rash is there. So safety is dose reduction recommended by guidelines are principal investigator. The first dose reduction is 30 mg per day and second dose reduction is 15 mg per day. And 45 mg per day is also like there's I'm sorry. 45 mg per day is also intolerable. If ever anyone wants to use it, it's 30 mg. It's not 45 mg at all for the dacomitinib. So 45 mg, one patient we used like long back, like 2 years before. The patient has significant diarrhea. Maybe for Indian population, 45 mg is not at all a dose to be used. It's 30 mg at least we have to start with. So quality of life compared to afatinib, there is a significant improvement in quality of life got noted. So first subsequent therapy, most of the trials, like whatever we use, this is time to next to subsequent therapy, first subsequent therapy, second subsequent therapy is there. In this also, osimertinib scored well. The time to first subsequent therapy is 25.5 months. Time to second subsequent therapy is 31.1 months. So all the boxes got ticked with osimertinib and perform. It's a very good TK compared to all other TKs, especially the second generation TK. So TKs are standard upfront, but all TKs are not equal. Just we discussed everything. I'm not going to do a repetition again regarding this. Be it efficacy or
Sorry,
safety.
Kripa, can you wind it quickly?
Yeah, sure, sure, ma'am. So subsequent second line treatment opportunity, like why we have to start osimertinib in the first line itself, because all of the patients, like we all know, the performance status will be deteriorated gradually once the patient passes the first line therapy. So all of us will not have an opportunity to start with the second line therapy properly. Only few patients will be eligible to start with second line therapy. So better to offer the best in the front line itself. So osimertinib is definitely the best drug to offer. So, and a few things, I mean, this is osimertinib is also adjuvant setting, no need to discuss regarding the ADORA trial. And few things I want to discuss, which are not included in the slides is, one is the combination of TK plus chemotherapy. The JEF-GC study presented by TMH as well as Tony Ma. It's a very good drug to use when osimertinib is like not accessible, because almost I would say 70 to 80% of patients are not affordable for osimertinib. Then that case, JEF-GC, the combination of chemo and TK is a very good combination to offer. Be it brain metastasis or without brain metastasis, there is not only just PFS, there's a good OS benefit is also there with this combination. And second one, not mentioned, was the EGFR plus ALK mutation combination. It's not unusual. Almost 5% of the EGFR patients will also lodge ALK mutation. The recently, again, the data got published by TMH. There is a good benefit of PFS as well as OS by combining two TKs. That's both ALK inhibitor and EGFR inhibitor. So that's a good combination to look into. Only pneumonitis we have to see. Erlotinib plus ALK inhibitor, there's an increase in toxicity is there. So gefitinib plus ALK inhibitor is acceptable. And third thing I want to see mention is the T790 mutation with EGFR mutation. So this combination, again, Rajnipriya, she didn't show that aspect, and she covered really well. So in that TK plus bevacizumab or ramucirumab, that population may have some benefit. If it's not feasible for bevacizumab or ramucirumab, that patients also can be offered this TK plus chemotherapy combination, because they don't do well with the TK alone. With this, I thank you for all for patient listening, and also Mahalakshmi for giving this opportunity.
Thank you, Kripa, for the excellent presentation. Next, I'll start sharing my slides. I'll be talking the real world data of osimertinib. We all have seen, just a minute. I hope my screen is visible. Is my screen visible?
Oh, yes, ma'am. Yes, ma'am.
Okay. So we have seen the trial data so far, the role of osimertinib. Dr. Kripa has elaborately discussed the role of osimertinib and all the safety aspects and why it scores over other EGFR TKs. But what is in the real world? If we see the clinical trial data cannot be extrapolated to the real world because only 2 to 4% of patients are actually take part in these clinical trials, and they are the only they're the very few percentage is a representative of the real world population. This real world data is very, very important in oncology practice, especially when we get data for the post marketing setting. And these are useful tools which provide insights for the usage of drugs in a routine clinical practice. So, if you see the real world evidence of osimertinib, we have three real world studies: the FLOWER study, the OSIPAC, and the MYCONO study. So, we'll quickly go through all the three studies and let's see how the osimertinib is doing in the real world. Coming to the first study, the FLOWER study. If you see the baseline clinical features, the median age 68 years. As you know, lung cancer is a disease of the elderly population, and the real world actually represents. If you see the clinical trials, most of the clinical trials, the age cutoff is around 65 years. This is because they don't want to take patients comorbidities. There are so many exclusion criteria, and all these patients are excluded. But real world data is not so. If it's a median age, it's around 68 years, which is quite an elderly population. And coming to the instance brain metastasis, around 30% of brain metastasis, we all know lung cancer incidence in the real world, around 20 to 30%, they have upfront brain metastasis. So this study is very much representative of the real world population and also stage 4 disease. Majority of lung cancer patients become an advanced stage. The early stage population is very, very low. So advanced stage 3C or especially stage 4, where palliative chemotherapy and palliative options are the only options available, where surgery is not possible, concurrent chemotherapy is not possible. So we see the real world majority of them are in stage 4. So there is an inclusion criteria for this study. They included all the patients with EGFR mutated lung cancer who are in stage 4 and who are receiving osimertinib. And patients who are already receiving the drugs in clinical trials were excluded from this study. And let us see the clinical endpoint. Usually in clinical trials, the primary endpoint is usually progression-free survival. That is what usually in the clinical randomized control trials. But in the real world, if you see the primary endpoint is median time to progression. That is median time to progression, which is measured from the osimertinib start to the discontinuation for any cause, and the treatment-related AEs. And TTT is under exploration. This is a pragmatic real-world endpoint to assess the effectiveness of anti-cancer therapy. And the secondary endpoints are median OAS, median PFS, and response rates and disease control rates. So if we see the assessment, the time to progression is 25.3 months. But in those patients who have no symptoms and the time to discontinue is less than 3 months, the median is not reached. And if you see, there are poor treatment outcomes for patients with brain metastasis. Their brain metastasis have done badly in spite of the drug crossing the blood-brain barrier and having efficacy in patients with brain metastasis. And those patients who have symptoms, they have done badly. And those are at least 3 metastatic sites at diagnosis. So all is suggesting that tumor load is a negative prognostic factor. That is, patients who are coming with a higher tumor burden, those patients have done badly in the real world scenario. And if you see the effectiveness, if you see progression-free survival around 18.9 months, which is replicating the clinical trial data. And in PFS in patient with no brain metastasis, median is not reached. And in PFS, and those patients where no symptoms also, the PFS is not reached. And if you see there was a discussion about rebiopsy after osimertinib. The previous speakers have been discussing that. But in this study, 47.7%, half of them done rebiopsy. And if you see the rebiopsy, tissue biopsy was done in 2/3 of them, liquid biopsy in 1/3 of them. And there were druggable resistance mechanisms, including MET amplification, MET and EGFR, and EGFR even HER2 amplification was noted in one patient. So safety data, we all know, osimertinib is a safe drug. The previous speakers have elaborated, and that is the same replicated in the real world also. Coming to the second study, the OSIFAC study is the same inclusion criteria where patients who are on osimertinib are included. The same baseline characteristics, if you say median age around 71 years, 68 years in the previous study, and this is 71, much older age group. Here the primary endpoint was progression-free survival. And efficacy endpoints, if you see, irrespective, especially in those patients with PDL1 less than 1%, they seem to have benefited better compared to other patients. And even if you see the hazard ratios, those with effusions who have higher disease burden, they don't seem to do much well on osimertinib. So as a whole, they have a bad prognosis, and those with higher disease burden, they're not doing well. Coming to the adverse effects, pneumonitis all grade is in around 12%, but if it's a grade 3, grade 4, it's less than 5%. That is one adverse effect which was noted in the real world. If you see from this trial, the overall response rates are around 76%, disease control rate 94%, and if we see the adverse effects, pneumonitis all grades 12%, but grade 3 or higher 4.5%. See, so PFS with osimertinib in the real world is favorable. So coming to the third study with the use of osimertinib, this is actually a prospective cohort study which is ongoing in Europe, Asia, and United States. And if you see interim analysis, the data has been captured from from the health records of the patients, and the interim analysis was done in June 2020. So let us see the interim analysis data. Around 58% remained on first-line osimertinib or were lost to around 58%. They remain on first-line osimertinib therapy, and 18.8% received second-line treatment. Around 18% died on first line, and around 5% discontinued first-line treatment. And if you see there are few endpoints in this study. There's real-world time to next treatment or death, which is designated TT and TT, and that was the median was 17.9 months. That is, and if you see what are the factors affecting this, the real-world time to next treatment or death, the factors are initial stage at the diagnosis, smoking status, Charles and comorbidity index, EGFR mutation type, and the number of metastatic sites. So all those patients who have multiple factors, they had a poorer outcome. And one more thing which was considered in this study is the real-world time to treatment discontinuation, TTD, which was also described in the flower study. The median TD is 17.2 months. We have seen 18.9 in the previous study, 17.2 in this study, almost similar to the trial data. In this also, if it's a multivariate analysis, there's certain factors which are affecting same, the Charles and comorbidity index, performance status, mutation type, metastatic sites, and evidence of liver metastasis. So from this study, we have learned that this study provides real-world insights into the use of first-line osimertinib. And this interim analysis, this supports the effectiveness of osimertinib in the real-world population. And long-term outcomes will be evaluated in the final analysis. So we have seen 3 real-world studies, and all of them have shown excellent survival with the use of osimertinib. Thank you all. So now we'll go to the next speaker. Next speaker is Dr. Anu Susan George. She's a medical oncologist from Lakeshore Hospital, Kochi. She'll be talking on the clinical endpoints in clinical decision making in early lung cancer. Dr. Anu?
Yes, ma'am. Just share my slides. Is my slides visible?
Yes, Anu, visible.
Yeah. Okay, so I'll be talking about the clinical endpoints in the decision-making in early lung cancer. Before I start, let me thank the organizers and Mahalakshmi Madam for the opportunity. So a brief introduction about this. So as we all know, what we mean by clinical endpoints is that it's an objective tool that is used to measure how beneficial a particular intervention is to either the survival or the patient's feelings and functions. And multiple endpoints may be evaluated that can arise either independent of the intervention or may be modified by the intervention. We generally classify them as primary endpoints, secondary endpoints, or tertiary endpoints. The primary endpoints usually are survival endpoints, and they are a direct measure on the drug's effects, while the secondary endpoints are usually quality of life indicators. And there can be either quantitative or qualitative endpoints. Quantitative endpoints usually are like survival data, and they're measured objectively by the amount of time that has elapsed from randomization or treatment initiation. And qualitative endpoints are usually subjective and are reported based upon the observations made by the patient or the caregiver or physician. So, are there any different efficacy endpoints which are required in the adjuvant and neoadjuvant settings in NSCLC as compared to advanced NSCLC? And if so, why? These are the things that we'll be looking at. So as we all know, the primary goal of adjuvant treatment is to eliminate micrometastatic disease. But the main problem with adjuvant studies is that it takes a very long time for the results to be available, typically about 8 to 10 years. For example, in this one study, the COG 1505, about a decade was required to report the negative results as negative. And so a lot of time is lost. So that is how, in the case of neoadjuvant treatments, however, what we do is generally downstage the primary tumor and make the surgery potentially less morbid, and also enables the analysis of the treated tumor. And so what neoadjuvant studies, they actually enable us to rapidly evaluate the efficacy without waiting for the OS endpoints. And so there may be some surrogates that are used in these neoadjuvant trials, like the tumor MPR or the pathological CR. And it drastically cuts down the time required to find out the role of the drug. For example, instead of 7 to 9 years it is required for adjuvant, it will usually take about 1 to 2 years. But the problem is that usually these surrogates are not there's no evidence for them prospectively. It's usually only retrospective data or that are usually available. So there are different efficacy endpoints that are available, which can be either clinical endpoints, pathological endpoints, or surgical endpoints. The clinical endpoints that we commonly use are OS, DFS, and EFS, while the pathological endpoints that we use are PAT-CR and major pathological response. I will talk more about major pathological response later. And the surgical endpoints like pathological complete resection rates. So these are different efficacy endpoints that we use in the adjuvant and neoadjuvant settings. So why do we need the surrogate endpoints? As we all know, though OS is the gold standard, the time required for getting OS data is usually very lengthy, and it might not be practical in all situations. And so we need surrogates for an earlier assessment of the treatment benefit. But a surrogate endpoint should actually meet some specific criteria. They should be able to predict the OS, and they should also be able to predict the effect of the treatment on OS also. So the effect on the surrogate should also be reflective of the effect on the OS. And they should also be validated for specific therapeutic classes. So that is the problem that we have usually, whether it is validated in all the therapeutic classes, including immunotherapy and TKIs. So the pathological endpoints that we commonly use in neoadjuvant NSCLC are usually pathological CR and MPR. And are they a suitable surrogates for survival after neoadjuvant treatment? You can see in these graphs that patients with MPR positive and MPR negative, similar survival data are there. I mean, they reflect the usual OS survival data. So is the PAT-CR an effective endpoint for neoadjuvant NSCLCs? And what is the difference between PAT-CR and MPR? So as we know, PAT-CR is defined as when there is no detectable evidence of tumor on the histopathological analysis. And usually, historically, in NSCLC, the neoadjuvant treatments have delivered very low PAT-CR, usually around less than 10%. The average is around 2 to 10%. And so because of this reason, is there a need for another surrogate? So that is how the MPR came into being. So it's not the same as the PAT-CR. In PAT-CR, there should be no detectable tumor in the resected tissue, whereas in MPR, there will be a less than 10% of residual viable tumor in the resected tissue. So it's the residual viable tumor is less than 10%. So the PAT-CR has been used as an endpoint commonly in neoadjuvant breast cancer, and it's now increasingly being used in lung cancer also. So what is the evidence for PATCR as a surrogate in the neoadjuvant setting? So in this particular analysis of two phase 3 trials of NSCLC, where their patients received neoadjuvant chemotherapy, 8% of these patients had achieved a PATCR. And when compared with the patients who did not achieve an PATCR, they did remarkably well at 5 years. There is an 80% survival and compared to 56% for patients who did not receive have a PATCR. So PATCR is found to be associated with OS based on these data in neoadjuvant chemotherapy. And looking at MPR as an endpoint in neoadjuvant NSCLC, MPR, as I said before, is the presence of less than 10% of residual viable tumor cells in resected lung and lymph nodal tissue after neoadjuvant therapy. Usually, this is in the case of chemotherapy. And this is how it is measured is in it's a pathological examination where first you need to, as a step one, you look at the gross maximum diameter of the tissue, and then take the H&E slides and section them with at least one section per greatest tumor diameter. Then you measure the percentage of viable tumor cells in each slide. And then you take the sum of the percentages of the viable tumor cells in each slide and divide it by the number of slides examined. That is how you get the mean residual viable tumor cell percentage. So is it an accepted endpoint for regulatory approval? It is not clear that whether MPR is of equal surrogate as PATCR, but it is increasingly being used in the neoadjuvant trials. So this is one data which is looking at two retrospective analysis of NSCLC who received a neoadjuvant chemotherapy. One was having patient number of 151 and the other 192. And here you can see that it is associated with an OS benefit, or reflective of the OS benefit. So what are the pros and cons of PATCR and MPR? So both of these, they allow an earlier assessment of the treatment effect when compared to either EFS or OS. And they require a shorter duration of follow-up only. And they're not influenced by the treatments that are administered after recurrence. And also the effect of the tumor attributable to the treatment is not, is not based upon the natural history of the disease also. But the thing about MPR is that it is more frequently achieved than PATCR. As I said before, in NSCLC trials of neoadjuvant NSCLC trials, historically we've got a very poor PATCR values. But when we use an MPR, there are higher rates achieved. But the problem with both of them is that it is not yet validated as a surrogate endpoint for OS in the neoadjuvant setting. So what about the role of these surrogates in the neoadjuvant TKI setting and in the case of neoadjuvant immunotherapy? In the neoadjuvant chemotherapy, it has been more well established, but the evidence is limited in the case of use of neoadjuvant TKIs or immunotherapy to a few small pilot studies and phase 2 studies. There are new phase 3 studies which are going on. So the current situation is that PATCR and MPR may be useful in the case of neoadjuvant chemotherapy, but whether they are useful in the case of neoadjuvant immuno or TKI and a combination of TKI immuno plus chemotherapy needs to be further looked into. So what about the clinical endpoints in resectable NSCLCs? So the usual endpoint that we use in resectable NSCLCs is DFS. This is the usual common endpoint. And DFS is defined as a radiographic tumor-based assessment. And it is from the time of randomization until disease recurrence or death from any cause. It is also known as recurrence-free survival. It is not the same as PFS because for PFS assessment, usually the patient will be having disease progression or disease will be present at randomization. Whereas in the case of DFS, that will be disease-free at randomization. And it is an endpoint that is accepted world over as a endpoint for adjuvant trials. Both in the breast cancer as well as colon cancer, it's regularly used. And in the case of NSCLC also, it is a suitable endpoint, especially in trials like the ADAURA trials, it has already been proven. So DFS and OS are usual surrogates that we use in NSCLC trials. And usually DFS is an appropriate surrogate endpoint for OS as reflected in the trials with chemotherapy. So both are usually reflective of each other. And it has been validated as a surrogate endpoint in the adjuvant setting for chemotherapy trials. But what about in the case of TKIs and immunotherapy? So in the case of TKIs, in the adjuvant setting, we have a few single-arm phase 2 trials and phase 3 trials. In this particular trial, which is looking at adjuvant erlotinib for 2 years after any planned adjuvant chemotherapy, it was a phase 2 study called the SELECT study. And here the DFS was significantly higher than the historical data. The 2-year DFS was 91%, and the 5-year OS was 86%. So the OS data was is not yet mature fully, and so it was not fully evaluable. But in the case of phase 3 trials like the adjuvant CTONG study, we have a totally different picture. So though there was a DFS advantage, it was not reflected in the OS in this trial. So we cannot say that DFS will be a surrogate for OS in the case of TKS with absolute confidence. Then again, this is a meta-analysis of 5 randomized trials using adjuvant EGFR TKIs. And these trials again show, sorry, I think this thing is missing, but it got cut out, I think. So in this particular slide, what they say is that there was a DFS advantage. There was a 48% reduction in the risk of disease recurrence. The OS data is missing in the slide, but what it said was that the OS was not reflective of the same. So there was no OS advantage again in this meta-analysis. Now, this is a phase 3 data, the ADAURA, the updated results of that. Again, after 3 years of the planned treatment with osimertinib, there was a DFS advantage, but the OS in the overall population, as well as in the stage 2 and stage 3A. But the OS data is not yet fully mature, and we'll have to wait for whether this DFS advantage will be reflected in the OS data also. So overall, whether the evidence for DFS as surrogate for endpoint in adjuvant NSCLC, it is a valid surrogate for adjuvant chemotherapy, but its role as a surrogate in the case of EGFR TKIs and in the case of immunotherapy require further trials, and as yet there is no clear validation of this endpoint. And this lack of OS benefit may be because of multiple factors. It can be because of patient heterogeneity, because of the duration of treatment, as well as the level of DFS benefit. And in the case of immunotherapy, also there are several ongoing trials which will require more the results need to be looked into further. Another endpoint that we can look at is the EFS. The EFS is a radiographic tumor-based assessment. It is from the time from randomization until progression of disease that precludes surgery, local or distant recurrences, or death from any cause. It's not same as PFS, because in the case of PFS, there is objective tumor progression, while in the case of EFS, it assesses the disease recurrence or progression that precludes surgery. So again, is it accepted as an endpoint for regulatory approval? Yes, it is an accepted regulatory endpoint for conditions like in neoadjuvant breast cancer, etc. But its role in lung cancer, again, needs to be looked into. Similar to the DFS, again, it allows for an earlier assessment of treatment effects, a shorter trial duration and follow-up, and is not influenced by other treatments that we give after recurrence, but again, not validated as an endpoint for OS in the neoadjuvant setting. Now, looking at some immunochemotherapy studies like the AGN and the Checkmate 816. I'll just go into Checkmate 816.
Susan, can you wind up quickly?
Yeah,
you're running short of time.
Yeah, 2 more slides only. Yeah. So this Checkmate 816 was again a neoadjuvant chemoimmunotherapy trial, which looked at nivolumab with plus chemotherapy versus chemotherapy alone in the neoadjuvant setting, followed by surgery within 6 weeks of chemoimmunotherapy, and then optional adjuvant treatment. So the primary endpoint was PathCR and EFS, and secondary endpoints are OS and MTR. So here we can see that when you compare with the traditional results of PathCR, which is, as I said before, usually less than 10%, and this is what was got in the chemotherapy arm also, it was only 2.2%. But the nivolumab combination showed a PathCR of almost 24%, which is surprising. Then another similar trial is the INCREASE design, which is looking at ipilimumab plus nivolumab, followed by nivolumab on day 28, along with chemoradiation. Again, after 6 weeks, there was surgery was done, and then they were followed up for the primary endpoints of PathCR and MTR. So the initial results from this trial also has come, and in again a very surprisingly high percentage of patients had PathCR. There was a 63% of the patients got PathCR, and an MTR of 79% was seen. So whether these data will be meaningful requires further evaluation, and further results also will be required. But these are probably endpoints that we can look at in the case of resectable NSCLC. So again, OS remains a gold standard, but because of the long follow-up and large patient cohorts required, we have to look at other surrogates like DFS. And there is some evidence for the association between PAT-CR and MPR as surrogate endpoints and OS for NSCLC, but it requires further data for convincing results. And we require more evidence in the case of EGFR TKIs and immunotherapy. Thank you.
Thank you, Dr. Anna Susan, for the nice talk. For the next talk, I would like to invite Dr. Monica Bopana. Dr. Monica is a consultant medical oncologist from KIMS Hospital, Hyderabad. She'll be talking on the safety of EGFR TKIs and which one to choose. Dr. Monica?
Yes, ma'am. Is my screen visible, ma'am?
Yes. You need to make it full screen.
Yeah, full screen.
Yes, please carry on.
Yeah, so a very good evening, everyone. I'll be talking about the safety of EGFR TKIs, which one to choose, how to decide on how to choose what TKIs, because we have 3 generations of TKIs now. So we know that these are mainly used for stage 4 non-small cell lung cancer, metastatic, and I would not go into the details of what are metastatic. We know this very well. And we know that in the diagnostic workup, tissue biopsy is required for knowing the mutation status. So I'll skip all this. Current metastatic NSCLC management is driven by molecular testing. And we know that targeted therapies are available for various mutations, mainly EGFR, and we also have for ALK, ROS, and MET also. And this targeted therapy has changed the treatment paradigm, and it has become the mainstay in the treatment of metastatic NSCLC with oncogenic drivers and also high PD-L1 expression. And it has improved the survival of metastatic NSCLC patients from 8 to 12 months to as high as 38 months, what is seen in FLORA trial. We have various mutations. EGFR sensitizing mutations are present in about 17% of the patients. And we have drugs available for that. That's geftinib, erlotinib, afatinib, dacometinib, and osimertinib. And we have KRAS mutations in about 1/4 of the lung cancer patients, NSCLC patients. And unfortunately, a drug is not yet available for this. The other rarer mutations, which account for anywhere between 1 to 4% of the cases, include PIK3CA mutations, NTRK fusions, RET, BRAF, ROS1, HER2, MET mutations, and other rarer mutations. ALK accounts for about 7% of the drivers. EGFR mutations and the drug resistance to EGFR TKIs, they tend to cluster at So they tend to cluster at the tyrosine kinase domain. We know that exon 18, 19, 20, 21, these are the exons where all these mutations are there. And they could be deletions, which are loss of a sequence of DNA. They could be insertions that are caused by additional sections of DNA being added. Point mutations occur when a single DNA base is changed to another. The 3 mutation types are found in structures around the ATP binding region of the EGFR, predominantly the phosphate binding loop or P loop, the alpha C helix, and the activation loop or A loop, and they are all at the tyrosine kinase domain. The most common mutation is exon 19 deletion, accounts for about 46% of all the EGFR mutations. And the next most common is the point mutation in exon 21, that is L858R, accounting for about 38% of the cases. The others, like exon 20, T790M mutation in exon 20, accounts for about 4% of the cases, and the other mutations are quite rare. So EGFR mutation positivity rate, EGFR mutations as oncogenic drivers are detected in about 50%. We know that the incidence of EGFR mutations is much higher in Asian population, and it's seen in about 10 to 20% of the Caucasians in NSCLC. In India, the EGFR mutation rate is about 25 to 30%. Most commonly found EGFR mutations are exon 19 deletions and L858R point mutations in exon 21. For patients with advanced NSCLC harboring exon 19 deletions or L858R mutation, EGFR TKIs are used as the first-line therapy. and the other mutations other than exon 19 deletions and L858R are considered as uncommon mutations. This is the journey of EGFR mutation, knowing how important it is in driving the tumor growth and how the drugs have evolved starting from 1993 to 2017. So if you see 1993, for the first time, attempts were made at developing an EGFR targeted therapy. In 2004, there was discovery that somatic mutations in tyrosine kinase domain of EGFR in patients with NSCLC are associated with response to geftinib. In 2005, there was discovery of the T790M mutation, which caused resistance to geftinib. In 2005, a placebo-controlled study in unselected pre-treated advanced NSCLC patients demonstrated PFS and OS benefit with erlotinib. In 2008, INTEREST study demonstrated non-inferior survival with geftinib as compared to docetaxel in unselected pre-treated patients with advanced NSCLC. In 2009, for the first time in a randomized fashion, IPASS was the first study to demonstrate significantly improved efficacy with first-line EGFR TKI, that's geftinib, as compared to chemotherapy in patients with EGFR mutated advanced NSCLC. From 2010 to 12, a series of phase 3 studies demonstrated superior efficacy of first-generation EGFR TKIs, geftinib and erlotinib, as compared to platinum-based chemotherapy in the first-line treatment of EGFR mutated advanced NSCLC. 2011 to 2013, we had the Lux Lung trials, which were done with the drug afatinib in the first line, and they demonstrated superior efficacy of afatinib, which is a second-generation EGFR TKI over platinum-based chemotherapy for EGFR mutated advanced NSCLC. They also showed clinical activity of afatinib in patients with some uncommon EGFR mutations like G719X, L861Q, and S768I. From 2015 to 16, Aspiration and IMPRESS studies showed benefit of treatment beyond resist progression with first-generation EGFR TKIs, but they showed that combination with chemotherapy post-progression has no additional benefit. From 2015 to 17, AURA studies demonstrated clinical activity of osimertinib in pre-treated patients with T790M NSCLC, later confirmed in AURA-3 as superior efficacy as compared to platinum-based chemotherapy. 2016 to 17, Lux Lung 7 and Archer 1050 demonstrated superior efficacy of second-generation EGFR TKIs afatinib and dacometinib as compared to geftinib as the first-line treatment for EGFR mutated advanced NSCLC. 2017 came the FLORA study that demonstrated superior efficacy of osimertinib versus the standard of care, the first-generation TKIs geftinib and erlotinib as the first-line treatment of EGFR mutated advanced NSCLC. And 2017, the superior CNS activity of osimertinib was shown both in the first as well as second line in the AURA studies as well as in the FLORA studies. Now, what are the considerations that we take when choosing the first-line treatment option in EGFR mutated lung cancer patients? We obviously want the drug to have a good safety profile, and we also want the drug to be very, very effective. So if you look at the efficacy, the PFS Kaplan-Meier comparison, the separation of curves in Lux Lung 7 that compared afatinib to geftinib, it started at around 1 year after starting the treatment, and then you see the curves separating. In Archer 1050, where dacometinib was compared to geftinib, the curve started separating at about 6 months. In FLORA trial, as compared to the standard of care, osimertinib as compared to the standard of care, it showed that there was immediate separation of curves starting as early as after 3 months of therapy, and the curves continued to remain separated. Of course, this is a cross-trial comparison, but this is just to give us an idea that the efficacy-wise, probably osimertinib is more superior as compared to the second-generation TKIs. So early and sustained survival benefit shown by clear separation of curves within 3 months, and that was maintained throughout the follow-up. Again,
Wi-Fi चला रहा हूँ मैं, hotspot चला रहा हूँ.
And again, if you look at the head-to-head comparison, it showed that the compared to the second-generation EGFR TKIs, osimertinib provided a longer PFS as compared to second as well as the first-generation TKI. So if you look at dacometinib, it was significantly higher as compared to geftinib the PFS of 14.7 months versus 9.2 months. That was statistically significant. And osimertinib, as compared to erlotinib or geftinib, 18.9-month PFS as against 10.2 months, which was statistically significant hazard ratio of 0.46. So PFS is a direct measure of drug benefit. There is an immediate separation of PFS Kaplan-Meier curves in the FLORA study, and osimertinib provided an unprecedented improvement in PFS in the FLORA trial. If you look at the safety, so these first, second, and third generation EGFR TKIs they have a different safety profile. If you look at geftinib and erlotinib, they are reversible inhibitors of the EGFR, whereas from the second generation onwards, second and third generation EGFR TKIs are irreversible. And if you look at the clinical targets, there's not much activity of geftinib and erlotinib on the wild type EGFR, whereas if you look at afatinib and dacomitinib, there is a significant action on the wild type EGFR. Probably that is the one that's responsible for, and also a significant action on the ERBB receptors also, that is the HER receptors, HER2, HER4, and that may be the reason why there's much more toxicity, especially diarrhea and stomatitis is much more in the second generation with the second generation TKIs. Osimertinib, on the other hand, specifically acts on exon 19 deletion, L858R, the other rare mutations, as well as T790M mutation, with hardly any activity on the wild type EGFR, and that's the reason why the toxicity profile of osimertinib is so good. We know the approved doses of geftinib 250 mg once daily, erlotinib 150 mg once daily, afatinib 40 mg once daily, dacomitinib 45 mg. This is very difficult to tolerate. Most of the time, it requires dose modification. Osimertinib is 80 mg once daily. The oral bioavailability of dacomitinib is very good, and even osimertinib has a 70% oral bioavailability. So if you see the geftinib and erlotinib EGFR sensitizing mutations, they mainly act on the second generation afatinib and dacomitinib act on the HER2 receptors also. Again, it's a pan-ERBB inhibitor, both afatinib and dacomitinib, whereas osimertinib is a selective EGFR inhibitor, and that is the reason why osimertinib has a higher superior toxicity profile. So if you look at the first and second generation EGFR TKIs, they have a much higher affinity. If you see, geftinib is somewhere in between the wild type EGFR inhibition, whereas for T790M, the concentration that required is very, very high. It doesn't inhibit T790M. For afatinib, at the dose that at the concentration that the IC50 that is needed for inhibition of the EGFR sensitizing mutation is the same as the IC50 that's needed for the wild type EGFR inhibition. And the second generation TKIs have shown some T790M, but it was seen that the concentration that's needed to inhibit T790M is very high. And by then, a lot of wild type EGFR occurs, and that is toxicity. So we can never use second generation TKIs that will inhibit T790M without a lot of toxicity. And if you look at the IC50 for inhibition of T790M and the sensitizing EGFR mutations is the same, whereas that needed for wild type EGFR inhibition is quite high, and that's why there is hardly any effect of osimertinib on the wild type EGFR, and that makes it much less toxic. So these are the roughly the percentages of toxicities for geftinib. If you see, for some unknown reason, the liver enzyme elevation is much more common with geftinib. And the incidence of diarrhea and stomatitis, if you see, is very, very high with the second generation TKIs, afatinib and dacomitinib. And osimertinib, the ILD is a little more, whereas all the others, the toxicity is very, very tolerable. So second generation EGFR TKIs lead to a higher frequency of adverse events. That's associated with pan inhibition of ERBB and such as rash and diarrhea as compared to first and third generation. EGFR TKIs induce rash and diarrhea. They're usually mild to moderate in severity, but the frequency of grade 3 or more rash and diarrhea may vary among the different EGFR TKIs. So it's higher among patients treated with afatinib and dacomitinib. And in the case of rash in erlotinib and geftinib, the frequency of grade 3 or more rash is slightly higher with erlotinib as compared to those treated with geftinib. The difference is probably because of a difference in the pharmacological properties between the two drugs. The reason of liver dysfunction, which is seen more with geftinib, is not very clearly known. Now, if you look at the Archer 1050 and Flora trials, again, I'm saying that this cross-trial comparison is not correct because of the different design and the different populations which are selected. But just to get a rough idea, if you look at the incidence of diarrhea, overall, all grades of diarrhea, it's 87% for dacometinib, paronychia is 61% for dacometinib, stomatitis is 44%, and dry skin is 27%. All these are much more than what is seen with geftinib.
Sorry, Monica, can you wind up quickly?
Yeah, yes, ma'am. So the diarrhea incidence is a much lesser with osimertinib if you see as compared to dacometinib. So adverse events of any grade were much higher with dacometinib in Archer 1050 as compared to osimertinib in Flora. So this is again the grade 3 adverse events also were much higher with afatinib and dacometinib as compared to osimertinib. So they have an unfavorable tolerability profile, and grade 3 and above adverse events are much higher with dacometinib and afatinib as compared to osimertinib. So at first line treatment, second generation EGFR TKIs lead to a higher adverse event. And if adverse event severity does not lessen or cannot be managed, the dose of EGFR TKIs should be reduced. Dose adjustments are more frequent with second generation EGFR TKIs. Osimertinib is very well tolerated at an 80 mg dose. The dose management scheme states that 40 mg dose also can be given under certain circumstances. So these data suggest that dacometinib is often intolerable at the starting dose of 45 mg per day, and often it needs to, it requires dose reductions. Almost 66% of the patients require dose adjustments with dacometinib in Archer trial. Again, this is the dose reduction. So if you look at the quality of life also, quality of life was much, there was improvement in osimertinib in Flora trial, a better improvement across all the scores as compared to geftinib. Whereas in Archer 1050, the patients with geftinib had a better improvement in quality of life. Some parameters improved with dacometinib treatment like disease-related symptoms, but quality of life went down because of diarrhea and stomatitis. So that's why quality of life parameters, patient-reported outcomes were also inferior with dacometinib, whereas global quality of life also, it worsened with dacometinib, whereas there was an improvement with osimertinib. So these are the managements of we need to grade the skin rash as well as the GI adverse events. We do the grading according to CTCAE, and whenever it's grade 3, we always interrupt the dose and we resume the TKI at a lesser dose. If it's grade 1 or grade 2, we can institute all these treatments like topical anti-inflammatory drugs, oral anti-inflammatory drugs like doxycycline, topical clindamycin can be used to reduce the dose. Grade 3,
Dr.
most
Monica,
likely patient.
can you do it fast?
Yes, ma'am. Yeah,
yes.
So this is how the rash is managed, and diarrhea can always be managed with anti-motility drugs. Any grade 3 or grade 4 adverse events, we need to preferably admit the patient and manage them as an inpatient, and antibiotic institution of antibiotics and all will be needed. So to summarize, we have the toxicity profile of second generation EGFR TKIs is much higher, and that's why we already have an approved third generation osimertinib that is far superior in the toxicity toxicity profile, and it has a better efficacy, better CNS activity, better patient reported outcomes, and that's why osimertinib is given as a category 1 recommendation even in NCCN and most of the other guidelines. Thank you.
Thank you, Dr. Monica. In the end, I would like to invite Dr. Rachna. Rachna is Assistant Professor of Medical Oncology from Nizam Institute of Medical Sciences. She will be talking on the role of TK in stage 3 non-small cell lung cancer. Dr. Rachna.
Good evening, ma'am. Mine is the last talk, and I will try to wind up as fast as possible. Thank you, Mehan ma'am, and thank you, AstraZeneca, for giving me this opportunity. Is my screen visible? Is my screen visible?
Yes, Dr. Rachna, it's visible.
Yeah, okay, ma'am. Sure. So to wind up today's session, I would briefly speak about the treatment of EGFR mutated early lung cancer. Till now, we were discussing about the advanced lung cancer, NSCLCs. So I would just speak briefly about the early lung cancer. As we all know, lung cancer is one of the commonest cancers in the world, and around 30% of the patients are expected to present with a resectable disease at diagnosis. That is the early stage lung cancer. And today we'll be discussing mainly about the stage 1B, stage 2, and stage 3A tumors, which are localized and resectable. So for these three stages, surgery is the primary treatment, and adjuvant cisplatin-based chemotherapy is recommended for patients with resected stage 2 to 3A NSCLC, and few stage 1B patients who have a poor grade of tumor, that is the poorly differentiated tumors, or who have an LVI in the presentation. So these tumors of stage 1B also may require adjuvant cisplatin-based chemotherapy, but that is a case-to-case based decision. And results from various randomized trials and meta-analysis have showed a 5-year overall survival benefit with adjuvant chemotherapy in patients with early stage NSCLC. And the hazard ratio for the survival benefit was 0.89. And for the disease-free survival, the hazard ratio was 0.84, which was also improved with the usage of adjuvant chemotherapy. Overall, disease recurrence or death following surgery and adjuvant chemotherapy remains high across all these disease stages. Though we are doing surgery and chemotherapy, the survival is not as expected as to be in an early stage tumor. So these are the recurrence rates for different stages. 45% in the stage 1B, 62% recurrences at 5 years in stage 2, and 76% in the stage 3. Coming to the EGFR mutation status in the early stage and the advanced stage, we have already discussed about the incidence of EGFR mutations in the Asians and the European populations and the Americans. The similar distribution of EGFR mutation is also seen in the early stage NSCLCs, highest being in the Asian population compared to the European and the American populations. So were there any trials which studied the use of EGFR TKI in the adjuvant setting? Yes, initially with the first generation TKIs, with erlotinib and geftinib, we have various trials like the SELECT trial, the adjuvant trial, RADIANT trial, EVAN trial, but all these have shown an improvement in the disease-free survival, not a major improvement in disease-free survival also, but overall survival was not beneficial in any of these trials. So we have a trial now with osimertinib. We have the data of ADAURA trial, which is osimertinib as the adjuvant therapy in patients with stage 1B to 3A EGFR mutation positive NSCLC, and this is after complete tumor resection. So this is the double-blind study, and patients were randomized to either osimertinib 80 mg or placebo. And the primary endpoint was disease-free survival in stage 2 and 3A patients, though they included stage 1B patients. Disease-free survival of stage 2 and 3A is the primary endpoint, whereas DFS in the overall population is the secondary endpoint. Coming to the inclusion and exclusion criteria, they have included adults more than or equal to 18 years of age, postoperatively stage 1B to 3A, with a confirmation of either exon 19 or L858R mutations. And patient may have received post-op adjuvant chemotherapy. It is allowed, but it is not mandatory. And there should be a complete surgical resection with margin negativity and a performance status of 0 or 1. And patients who have received either pre or post-operative radiotherapy or preoperative chemotherapy were excluded from the study. And also those patients who underwent segmentectomies or wedge dissections were also not included. Only those who underwent lobectomies were included. The baseline characteristics were well matched between the osimertinib group and the placebo group. Adjuvant chemotherapy was given in around 60% of the patients in both the groups. So coming to the primary endpoint of disease-free survival, in the stage 2 and stage 3A, and it was not reached in the stage 2 to 3A population with osimertinib, whereas it is 19.6 months with the placebo, with a hazard ratio of 0.17. And in the overall population also, that is including stage 1B, 2, and 3A, the hazard ratio was 0.2, with DFS not being reached in the osimertinib group. So in all the subgroups and also the overall population, the disease-free survival was significantly improved with the usage of osimertinib post-surgery. So coming to the 2-year disease-free survival and across the different groups, with the osimertinib, the 2-year disease-free survival in stage 1B was 88, stage 2 was 91, and again stage 3A was 88. And in all the groups, the disease-free survival at 2 years was significantly improved with the usage of osimertinib. And this is the subgroup analysis. We can see from this forest plot that all the subgroups have benefited with the usage of osimertinib compared to placebo in the adjuvant setting. And this is the overall survival curves. This is still immature. The maturity is only 5%. The overall survival is still not reached in both the osimertinib and placebo groups, but the hazard ratio is 0.40. And coming to the recurrence rates, 11% of the patients in the osimertinib arm had some disease recurrence or death, whereas 46% of the patients had an event in the placebo arm. And majority of the patients in the osimertinib group had a local regional recurrence, and only 38% of the patients having metastatic recurrence compared to 61% of the patients in the placebo arm. So the disease recurrence in the osimertinib group was mostly local or loco-regional, whereas in the placebo it was metastatic. Why is this important? Because those patients who have a local or regional recurrence, they have a longer post-recurrence survival than those patients who have a distant recurrence. And also preventing CNS recurrence is one area which is unmet in the localized NSCLC. Most of the patients with localized NSCLC do present with a CNS metastasis on progression. So when other EGFR TKIs, the first generation TKIs were studied, they could not address this problem of the CNS recurrence. But osimertinib has shown to achieve clinically significant exposure in the brain compared with the other first generation TKIs, and it has a greater penetration of the blood-brain barrier. So these are the sites of recurrence in the ADAURA trial. So with the patients with osimertinib and the placebo, we can see some patients with osimertinib do have CNS progression, but it was very, very less, only 1%. So these are the CNS disease-free events in the osimertinib group and the placebo group. Overall events were 6, 2 deaths and 4 recurrences of CNS. That is only 1% of the patients in the osimertinib group had a CNS recurrence, whereas in the placebo group, 10% of the patients had a CNS recurrence. So what is the CNS disease-free survival? It is still not reached in the osimertinib group compared to 48.2 months in the placebo group. The hazard ratio being significant. This is a hazard ratio is almost similar to the overall disease-free survival in the osimertinib group, and the placebo group, the median survival is only 48 months. And coming to the safety, the expected toxicities of osimertinib were seen in this trial. There were no new toxicities or there was no major intolerance seen by most of the patients. And any grade more than 3 adverse events were seen in around 20% of the patients with osimertinib. And median duration of exposure for osimertinib was 22 months compared to placebo of 18.4 months. The most dreaded toxicities of interstitial lung disease or the QTc prolongation were seen in very limited number of patients, that too in the grade 1 or 2 only, not grade 3 or grade 4. We can see that when we compare to the placebo, the stomatitis is one of the commonest toxicity of this osimertinib, which had a grade 3 or grade 4 events. And diarrhea also was grade 3 or grade 4, but rest of the side effects were only grade 1 or grade 2. And there was further analysis of the ADAURA trial. One of that analysis which was published is the post-operative chemotherapy use and outcomes from ADAURA trial. So overall, 60% of the patients have received adjuvant chemotherapy in the ADAURA trial for a median duration of 4 cycles. And the majority of the patients have received platinum-based chemotherapy. And most of them were either stage 2 or stage 3A. And adjuvant chemotherapy was mostly used in patients who are less than 70 years of age. So what is the disease-free survival in the patients who have received chemotherapy and who have not received chemotherapy? In both these subgroups, osimertinib has shown a significant improvement in the disease-free survival compared to placebo in patients who have received or did not receive adjuvant chemotherapy. And it was the benefit was more pronounced in the patients who have received adjuvant chemotherapy, with hazard ratio being 0.16. Whereas in those patients who did not receive adjuvant chemotherapy but have received osimertinib, the hazard ratio is 0.23. So either the patient receives or did not receive adjuvant chemotherapy, osimertinib has shown to improve the disease-free survival. And this is the forest plot of the patients who have with and without adjuvant chemotherapy according to the stage of the tumor. And we can see that both the stage 2 and stage 3 tumors with or without adjuvant chemotherapy have benefited with the usage of osimertinib. And coming to stage 1B patients, in the patients who have received adjuvant chemotherapy, it is not still matured. The results of disease-free survival in the patients in stage 1B tumors who have received adjuvant chemotherapy is still not matured. Hence, we can see in this forest plot that only those without adjuvant chemotherapy have been analyzed, because those with adjuvant chemotherapy, the results are still immature. Whereas in those without adjuvant chemotherapy, the benefit of osimertinib still continues in the adjuvant setting. And in stage 2 and stage 3, the Kaplan-Meier curves are showing a wide gap between the curves of the osimertinib and placebo in patients with and without adjuvant chemotherapy. So another outcome from the ADAURA trial was the patient-reported outcomes from the ADAURA, which have studied the quality of life analysis. They have used the SF36 questionnaire, And they have analyzed various components, especially the physical and mental components, including the physical functioning, physical roles, bodily pains, general health, and various other factors were included. And the data collection period was at the time of surgery, at the time of randomization, week 12, week 24, and again repeatedly every 24 weeks of the total period of 3 years for which osimertinib was used. So over time, the compliance rates with the SF36 health survey were high in both the osimertinib and placebo group. We can see the curves are going hand in hand. There is no difference in the quality of life with the usage of osimertinib compared to placebo. And time to deterioration of the physical and the mental component summary was also done. And here also we can see that the curves are going together. There is no difference with the usage of osimertinib or placebo on the quality of life of the patients. And during the disease-free period, the majority of patients did not experience a clinically meaningful deterioration in either the physical or the mental component summaries. So to summarize, adjuvant osimertinib is the first targeted agent in the global trial to show a statistically significant and clinically meaningful improvement in the disease-free survival in patients with stage 1B, 2, 3A EGFR mutant resected NSCLC. There was a reduction of 80% in the risk of disease recurrence or death with the usage of osimertinib. And at 2 years, the disease-free survival was 89% compared to 52%. And it is also demonstrated a clinically meaningful improvement in the CNS disease-free survival, which is one of the important risk factors for recurrence. The CNS recurrences are very difficult to tackle, and preventing a CNS recurrence would actually improve the overall survival and disease-free survival, and also the quality of life for most of the patients. And the safety profile was consistent with the established safety profile of osimertinib. And the meaningful benefit of DFS was seen in both the patients who have or not received the adjuvant chemotherapy, with the hazard ratios being 0.16 and 0.23. And higher disease recurrence observed among patients in the placebo arm who received adjuvant chemotherapy compared to those who did not were likely driven by the large proportion of the patients who are stage 2 or 3A. And overall health-related quality of life was maintained with adjuvant osimertinib, with no clinically meaningful differences versus placebo. So to conclude, adjuvant osimertinib will provide a highly effective practice-changing treatment for patients with stage 1B, 2, 3A resected NSCLC, and especially for those who have a complete resection. Thank you.
Thank you, Dr. Rachna. I thank all the speakers and the panelists for their active participation and their insights, the practice changing their insights. And I would like to thank AstraZeneca for this opportunity. And I thank one and all. Over to the organizers.
Thank you so much, ma'am. Thank you to support us all. And the session should close, ma'am.
Yes, we can close the session.
Okay, support team, you can close.
Thank you.
Thank you, ma'am. Thank you, everyone.
Thank you.